test. So this is the new stuff you haven't had yet. Hopefully this stuff is going to make, the stuff that we went over earlier is going to make more sense when we do renal failure and whatnot. But we're going to just go through this. A lot of this is common sense. You've probably even experienced some of these before. I do want you to spend a little bit of time. If you invest some time here on this slide, you will spend less time memorizing things for renal failure and the cues for renal failure. So I put this here, but I also put it at the beginning of the renal failure lecture. Probably applies a little bit more for this. So the kidney has 6 jobs. Lungs got 1 job. The heart's got 1 job. The kidney's got 6. And so the kidneys are pretty important for us. And let's just see. I think I spent most of the time on the 6 jobs for the kidneys in the renal failure lecture because that's going to make sense for all your signs and symptoms of renal failure is when they stop doing their jobs, right? When they stop doing their jobs, we go out of balance on all of these things. So I will save that for the renal failure lecture because that's where we're going to spend time on that. This is just basic anatomy review. And the one thing I guess I want to point out on here, I think this is an interesting, does anybody, did you ever know your bladder capacity before? Or what the bladder capacity was? I like to say this is I better get off in the next exit to go to the bathroom. Like, yeah, I could probably go to the bathroom if I needed to go. That's about 200, 250. This is, I got to get off like now. Where's the next exit? Like, I got to go. Like, this is really happening. And this is, I'm leaking. Most of us don't get to bladder capacity. The bladder can even go all the way to like 2,000. It can stretch. But the more it stretches past a liter, you actually can damage your bladder wall if it stretches longer than a liter. So the other thing about the bladder being at capacity is once your bladder is at capacity, so I like to draw it. Oh, whoa, I drew way wrong. But when your bladder is at capacity and filled, it starts refluxing up to the kidney. There's no more room in it anymore. It will stretch a little bit, but it doesn't. How come it's not? Hang on, you didn't get to see my pretty drawing. Why did you not show your pretty drawing? Hang on. Now it's drawing. Sorry. So, long story short, reflux. Go back. Draw. Oh, it's not showing. I'm sad. You're not going to see my drawings. Well, anyway, I don't think I have too many drawings on this one. But if your bladder gets full, so if we drew on the bladder and filled it all the way up and it distended, once it gets past the, like a balloon, it has a maximum kind of capacity, and you can stretch it further, but it doesn't like that. So the path of least resistance is the reflux up the ureters back into the kidney. So when your bladder hits capacity, you start having reflux up to the kidney. We don't want reflux up to the kidney because think about junk that's in your bladder. Your bladder's a big storage area. There might be bacteria in there. There might be stuff in there. And if that reflux is up to the kidney, now we've introduced things up into the kidney. So we want to avoid that reflux if we can, and we avoid reflux by avoiding getting us to bladder capacity. So let's see what other interesting things we have. I don't go over renal vocabulary, but if you don't know these words, these may be words that come up on test questions or case studies or in charts. And so I just tried to put some of the common words for any kind of renal vocabulary up in there. You can read through that. The blood work, anything in bold, I would want you to know. So the electrolytes you already got on the last one, but just in case you didn't look at that old one because it was a review slide, I put the electrolytes there again. So what I like to make things simple. You can learn ranges from your book if you want, but again, simple is better. Your BUN and your creatinine are your main kidney numbers. These are waste products that your body makes. Your body makes urea and creatinine as a waste product, and your kidneys are supposed to get rid of it. So we measure them to see if we have a lot of waste products roaming around. Then it could be a sign that your kidneys aren't working and getting rid of the waste products. So creatinine, I like to think anything less than 1 is normal. You might get things in your book that say, 0.6, or I don't know what your book says is normal for creatinine, but less than 1. Just remember less than 1. Anything 0 point something is a fine creatinine. Once it starts to climb higher than 1, we're starting to worry, why is there so much creatinine wandering around? BUN is blood urea nitrogen, and that is from the breakdown of protein. And again, we like to keep that less than 20 roaming around. If your BUN starts to climb higher, we're like, why is there that much roaming around? There's lots of reasons your BUN and creatinine could be high other than just kidney problems. But usually when the two are both high, you probably have some problem with your kidney and being able to excrete these waste products. If you're dehydrated, what do you think is going to happen to these values? Are they increased or decreased? They're increased. So if you are dehydrated, you may have an increased BUN and creatinine. But there's nothing wrong with your kidneys. But once you rehydrate your patient, that should come down. So sometimes you may see that your BUN and creatinine are high in dehydration. And that is because of those lab value things that are going on. It could also be that if you are a bodybuilder or you like to work out or you take creatinine, you could take creatine. If you take these things, you may have higher levels. So we're not saying that this is automatically kidney failure, but it's a high indicator of kidney failure if your BUN and creatinine are high. And so I like to remember that it's usually a 20-to-1 ratio, and if they start climbing above 20-to-1, then we probably have something that we need to keep monitoring. The glomerular filtration rate is the only other thing I need you to memorize, and that is a rating for chronic kidney failure. And we like to make sure that this is basically how much blood is being filtered through the beginning of our kidney, and we want it to be greater than 90. If it's less than 90, that could be a sign of chronic kidney failure. So those are the 3 numbers for kidney values that I really want you to kind of remember. In terms of lab work that we can do and draw, those would be the 3 that we're going to draw and watch for the kidney. And then the next one is urinary analysis, which basically we should not be peeing out anything in our urine except waste products. So you should not see any of these things: protein, glucose, ketones, red blood cells, white blood cells, bacteria, casts, crystals. None of that should be in there. Those are all signs that something is wrong in the urinary tract. So your pH, again, none of this is bolded. Don't worry about it. Don't worry about it. But just know that your urinalysis is usually clear. You usually have a urine pH. The specific gravity is another measure, like osmolality, of how much junk versus water is in there. So a kidney that is putting out very, very clear, yellow, clear urine is going to have a low specific gravity. Meaning there's more water than junk, right? There's a lot of water and not a lot of junk, okay? Your kidneys are putting out more water than junk. Just means you're diluted. If you're putting out very, very thick, concentrated stuff that's like amber colored, that's because your body's not putting out a lot of water and all it's putting out is waste products. And so it becomes highly concentrated urine. The thing is if your body has fluid in it, so the urine-specific gravity does not match your blood osmolality perfectly. This is just a measure of what your body is peeing out. So let's just look at all the differences once we get to the labs. The bladder scanner. I do want to put in the bladder scanner in your Geo basic assessment. Again, you did this in block 1, but you probably did a lot of stuff when you did the Geo system. I'm getting it down to that's all you need to know. That's all you need to ask about, and any urine problem is going to get this urine assessment. How are you producing urine? What kind of color and consistency is the urine? Is there any pain with urination? And what is the actual output? Did you learn the 0.5 milliliters per kilogram? If you did not, that is your standard now. 0.5 milliliters per kilogram is normal. What did you learn for normal urine output?
30 mLs an hour.
30 mLs an hour is great, but you versus Ryan in the back, you're going to put out different amounts of urine. You're different sizes. So the American Kidney Foundation has determined that everybody should put out 0.5 milliliters per kilogram. That is the standard. That is from the renal docs and the American Kidney Foundation.
Is that
Okay.
per hour or?
Per hour. Yes, that's great. 0.5 milliliters per kilogram per hour. Yes. So, oh, no. Wait. Let me think about that. 0.5 milliliters per kilogram. So let's say I'm 100 kilos, 50. Yes, so that's about right. So it's per hour. Thank you. So add that on your little thing. Let me see if my drawing is working now that I can see. No, my drawing's not working. I got to sort that out at lunch. But 0.5 milliliters per kilogram, which makes sense because if you are an 80-year-old lady, so let's say you're 40 kilos, I guesstimate, because you're about 80 pounds, you're undernourished, you're malnourished, that little lady could put out 20 milliliters an hour, and it'd be okay because she's 40 kilos. Now, a 100-kilo guy who's 300 pounds, they got more waste products, they got more stuff. So they're going to put out more urine output, okay? So size-based is better. Now, 30 still makes for a good baseline, but you do have to take into account that someone who is 6'5" and 300 pounds is going to be putting out a lot more urine than someone that's 4'9" and 100 pounds.
So should we use this on the NCLEX? Will it be?
This is the standard, and this is where you're using this as your, when am I worried? Now, if you don't know your kilos of your patient, we'll start getting worried at less than 30 milliliters per hour. Because think about it, a 100-kilo guy should be putting out 50 an hour. So yeah, I'm going to be worried if they're 30. Most people, most average adults, are about 80 kilos, which is 40 milliliters an hour. So I'm going to be worried if they're putting out 30 milliliters an hour. That's a good average guesstimate for most people. But if you do have those little tiny people, I used to be a little tiny person, but yeah, a little 5 foot, 50 kilo person, I'm not going to freak out if they're putting out 25 an hour. That's normal for them. Because that's her, she's 50 kilos. She doesn't weigh anything. She doesn't have any body mass. So they're not going to be putting out as much urine output. But, so that's probably the exception to the 30 milliliter an hour rule, are the really teeny tiny people. But really, most people should be putting out at least 30. But the thing is that we are not worrying until they're 30, but we should have been worrying earlier. And so we've missed people. Because the big 6'2" guy who's 300 kilos, that boy, by the time he's putting out 30 milliliters an hour, he's well gone into his normal output. He's way below his normal output. So just 0.5 milliliters per kilogram is a better and more specific guide onto what people should be putting out. And when you start talking about patients in renal failure or going into stages of renal failure, we want to be more specific about their urine output. But 30 will work because 30 you worry about, and you should worry about 30. For most people, 30 is too low. Okay? If you're worried about their urine output, the next part on our assessment should be a bladder scan. I do have a bladder scanner that I will bring to class next week, and you can play with it. I'll put a little IV bag in their pelvis, and you can measure the bladder. Because the bladder scan is part of the urinary assessment. If you are in a hospital with a bladder scanner, use it as part of your assessment. We can't just go up there and see how much is in the bladder, but with a bladder scanner, you can. You can just put it right over their bladder and scan it and see how much fluid's in there. It's like a little radar. And it measures how much fluid is in there, because that will help us decide what the problem is. If you're not putting out urine output, but your bladder is full, that's a different problem than you're not putting out urine output and your bladder is empty. We have different problems there. If you're not putting out urine output and your bladder is empty, it's because your kidney didn't make it. If you are not putting out urine output, but your bladder is full, it's because you have an obstruction. You can't get it out of the bladder. So the bladder scanner is a great, non-invasive, quick way to figure out if your no urine output is because of an obstruction or a kidney problem. So the bladder scanner is a next step in your assessment, and you certainly probably want to do it before you call a doc about low urine output, because it's more information. And we are always looking to get the most information we can before we call someone in for a problem. So what you're going to be trained to do is, hey, I think there's a problem. Define it in your head. What is this problem that you think? Low urine output. So this is different than all the care plans you learned in nursing school, because you had to give nursing diagnoses and all that. Nursing diagnoses are going away. They're not going to use them on NCLEX anymore.
Oh, really?
Nope, they're gone. Out. Because our job is a teammate. Our job is to be a teammate, to understand what we're going to be asking for. We're going to be talking to someone who doesn't want a nursing diagnosis. They want a probable diagnosis. They want to know, what do you think it is? Well, there's no urine output. Why? We can do one more little investigative piece to get down to the bottom of it. Well, there's no urine output, but the bladder's full, so it's an obstruction. Well, there's no urine output, and the bladder's empty as a stone, so something higher. You're going to have to decide your orders from there. But the more information you can give, the better orders you're going to get. So bladder scanning is part of the bladder assessment, so if you ever call a doc in sim or in real life and you're like, my urine output's down, and they're going to be like, do they have urine output? Is the kidney bad, or is it an obstruction? This is the more than that 600 milliliters or 1,000 milliliters of the bladder can cause backflow to the ureters and cause kidney damage. No, the bladder, we got a problem going on. So bladder scan is part of your assessment, is the key to that. Let's do the actual disorders. So here's where you start making your remit guides. UTI is just a urinary tract infection, and it calls anything in the urinary tract is a UTI, including your kidney. Your kidney's in the urinary tract, so it is a upper urinary tract infection. The lower urinary tract is your bladder and your urethra. So the stages, hopefully, we're going to keep people out of the higher stages and keep people in the lower stages. Usually bladder UTIs come from the outside and work their way up. We all know that, right? Yay. So here's your cues. This means you have it. You have frequency, burning, urination. You have incontinence. You can have vague lower abdominal discomfort. You don't need all of them. Some people don't have anything other than cloudy, foul-smelling urine. They don't have any pain. Depends on their nerves and their bladder and how they function. So some people have all these symptoms. Some of them have one of those symptoms. So there's no guarantee on what your symptoms are. But cloudy, foul-smelling urine is a good cue that something, why are you peeing out stuff that smells bad? That's usually infection. In the urinalysis, remember, we weren't supposed to see anything. But now we've got an infection in the urethral tract. So what are we peeing out? Well, white blood cells, because they're in there trying to fight the infection. So we're peeing out white blood cells. We're peeing out casts, which is basically the debris from the fight that's going on there when the white blood cells are in there trying to kill whatever infection it is. Increased red blood cells. Why would we have red blood cells in there? What are the bacteria doing to your urinary tract? They're having lunch. Munch, 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 munch. It's up there in those urinary tract, in those bladder cells. It's just munching on stuff. So as those bacteria are in there, they can actually scrape up and destroy some of your urinary tract. So you might get some red blood cells in there. You would have white blood cells because of the infection in there. So any or none or one of those cues can show up. If it is moving up the urinary tract, we consider pyelonephritis a worsening cue. So if you've had a urinary tract infection for a couple of days and never got it treated, bacteria nom 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 nom, they're going to move up, and they will nom 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 all the way up the urinary tract and into the kidney. Once they get into the kidney, it is called pyelonephritis. You still can have any or all of those cues, but you will also add high fever, chills, and flank pain. If a patient comes in with their hands on their back like this, they probably have something kidney related. The kidneys sit right beneath your rib cage in your backside. They're in the middle, but they're behind your intestines, and so you feel the pain in your flank, the flank and the back. So wherever you put your hands, when you put your hands on your hips, where your thumbs are or where your kidneys are. And that is where people feel the pain. They will have lower back pain and side flank pain. So if you've had a UTI for a couple of days, maybe you knew about it, maybe you didn't, depending on your existing cues. But if you end up with high fever, chills, flank pain, nausea, emesis, those are signs that it has moved up into your kidney. And then if we keep going, then you can actually destroy your kidney from these bacteria. Because remember, they're nom, nom, nom. Those bacteria are just eating stuff. They're eating up your urinary tract, they're eating up in your bladder, they're eating up in your kidney, and they can actually destroy your kidney if you let them stay there long enough. So pyelonephritis can become acute kidney failure. And when we talk about acute kidney failure, we're going to talk about the 3 causes of acute kidney failure. And this is an inside the kidney problem. This is bacteria in the kidney causing renal failure. So you will have all these pyelonephritis cues, plus you will have signs of renal failure, which is going to be increased BUN creatinine, decreased urine output, and some fluid retention. Then if it keeps going from there, it can get into the bloodstream. So any highly vascular organ, like the kidney, the lungs, and the liver, if you get infections in there, those infections transmit to the bloodstream very easily because you've got lots of blood vessels in there, and bacteria, and they're supposed to be exchanging stuff. So like your lungs are supposed to be exchanging gas, but they can exchange bacteria. Your kidneys are supposed to be exchanging things out of your blood, but bacteria can easily get across those thin membranes. So organs that have a lot of blood flow usually can cause sepsis very quickly, and that's a bloodstream infection. So you can go in with existing cues, or you can come in with worsening cues, but I would like you to perk your ears up and widen your eyeballs a little bit for someone coming in with any worsening cues. Or if they have these cues and they start develop worsening cues, that's where you need to make a phone call. Okay? If they came in with a UTI, or they came into your urgent care, your ED, with a UTI, they're going to get antibiotics and go home, but you need to pop up and widen your eyebrows and call someone if they have these worsening symptoms, because they probably shouldn't go home with these worsening. They need more of a workup or more looked at. They shouldn't be going home. And so if you see any of these patients that they're going to get discharged, but they have these cues and they have any worsening cues, don't let them get discharged. Like, no. we need to assess this. So that's UTI. Again, I just have your same Geo assessments in there for you monitor because we need to categorize it. So when you have cues, you need to categorize it. Like, I think this is a UTI. Now, I know that's not a NANDA nursing diagnosis, but they have cues of a UTI. I think they have a UTI. It's not been adjusted in the chart. What level of UTI do I have? Then you would say, all right, we're worsening, or they just have it, or they've had it for a while and they're improving. We have to categorize where they are in the system. We don't notify someone for if they had it in their history. They came in with a UTI. It's in their chart. We don't need to notify anybody they have it. We need to notify them if they're getting worse. Does that make sense? So that's why I separate those all out. And what we do about a UTI, if you have not already, get a urine specimen. That's why if you come in with signs of a UTI to an urgent care, they'll send you right to the bathroom to get a urine specimen, because that's number one. So if your patient presents with signs of a UTI, or they didn't have a UTI when they came in and now they've got signs of a UTI, get a urine specimen, because you always got to get a specimen before you start antibiotics. Wherever you think is infected, get a specimen of it before you start antibiotics. The medication's antibiotics. Give them their antibiotics. I put a little star next to it because I have another slide about it in the pharmacology section. And then if they're having pain relief. Fluid is great for flushing anything, especially bacteria. So if you can handle fluid when you're infected of any kind, flushing bacteria is a great idea. Get rid of it. The only time we don't increase fluid intake is if you're already in renal failure. Hopefully we're not, because that's like one of the worst things that can happen from a UTI. If they had an indwelling catheter, try to take them out. In fact, I think, who was telling me they have to straight cath now in the ED 3 times before they're allowed to put a Foley in? Which doesn't make much sense to me, like why that's a new policy. Because I'm like, why would you try to give someone an infection 3 times before putting in? But I guess they found that indwelling catheters have a much higher risk of urinary tract infections. So this would be a great case where your patient didn't come in with a UTI at all, but they got a Foley for something else, and now they're showing cues of a UTI.
I was actually told that yesterday in L&D they have to straight cath them
Yeah, that's a new policy that Dignity put out, and we were rolling our eyes at it. But anyway, because they would rather use straight cath and pull it out than leave it indwelling, because it's just a railroad. It's a direct route, a hyper-express pathway for bacteria to get up into the bladder. So they can just climb up those little catheters without any trouble. They don't meet any white blood cells. There's a thump, they're right in the bladder. And then once they're in the bladder, they can get up to the kidney. So.
Are there any antibiotics that can put on that to make it so it's more stable?
No, because then now we've got antibiotic resistance going on. So if you put in antibiotic-coated catheters, I'm sure they've tried them at some point in the past. I haven't seen them, but you got people who are allergic to antibiotics, so they wouldn't be able to get them. And then you wouldn't find out about it until their whole genital area swelled up. And you're like, oh, you're allergic to that antibiotic, because that happens with chlorhexidine and stuff like that, too. So basically, they are getting rid of, the days of free Foleys are going away. They are really not, because did you guys know that if a patient gets a secondary infection, like a UTI, while they're in the hospital, Medicare doesn't pay? You can come in for heart surgery and have a 1-month stay because of your complicated heart surgery, but you got a UTI from the catheter. Medicare's like, we're out. That was free. So, of course, the hospitals are like, oh, heck no, because now we just gave away a month of care for free. We can't afford that. So hospitals crack down on these big time. CAUTIs, which are central line associated infections, catheter-associated urinary tract infections, or CAUTIs, and CLABSIs, which are central line-associated bloodstream infections. Those two things get Medicare out of paying and put hospitals way in trouble. So basically, as soon as you end up with a CLABSI or a CAUTI, the hospital isn't going to get payment from Medicare. And it goes on a reportable thing, and it makes your hospital look dirty and stuff like that. So they are really adamant about these, even though we roll our eyes and we're like, UTI is not even a big deal. Just give them antibiotics. But it's a secondary infection that they didn't come in with, and then they got because of something you did. And Medicare's like, yay, we don't have to pay dirty hospitals. But the hospitals are like, well, now we're out the money for that whole stay. And that gets reflected in your paycheck. So this is something that actually your CAUTI and CLABSI rates on the units affect your pay. Because they put the CAUTI and CLABSI rates on everybody's performance eval. Yeah, so if you work in an ED that puts in a lot of Foleys and there's a lot of CAUTIs, then they're going to be like, no, this ED's dirty. Everybody in the ED gets a pay cut because your CAUTI and CLABSI rates are high. So hospitals are tied, and it's not just because of what the effect on the patient is. They really are just like, nope, this patient didn't have a UTI when they got here. You gave them a UTI. We're not paying. It used to be they would just not pay for the area, and then they finally just said, no, we're not paying for the hospital stay. So the hospitals are very, very interested in keeping these rates down because it affects their payment. So you're going to have to fight to get a Foley these days. We give them to you a lot in lab because we want you to put a Foley in and get that experience and that skill. But you actually kind of have to fight to get a Foley these days in the hospital because of the risk of infections coming on after. So that's a little political aside. Your antibiotics, at this stage, there is some research out there about the course of antibiotics. We do teach our patients full course of antibiotics. There is some research out there on taking antibiotics till your symptoms go away, because the less you're exposed to an antibiotic is supposed to reduce your antibiotic resistance, but then also not taking antibiotics for the full course and keeping a low level in antibiotics makes the infection come back. So there's not real good research. So full course of antibiotics, even if your symptoms go away, take all of it. And this one is a special, so antibiotics, I'm not going to go over. You've seen, there's just different kinds. And again, you don't need to memorize that because you're not prescribing it. But I would like you to just recognize if your patient had a UTI and is on a cephalosporin, that's appropriate. That's a good antibiotic for it. That's usually what they do. They pick antibiotics based on the most common bacteria to infect that area. So pneumonias get a certain kind of antibiotics. UTIs get certain kind of antibiotics. Endocarditis get certain kind of antibiotics. They just kind of know what those, they give you the antibiotic for the most common coverage, and then they wait for the urine results to come back, or your catheter, or your culture results to come back, to then change your antibiotics if you need to.
That was just my question.
Yeah.
Do you have culture on
Yes, and so you got your specimen ahead of time. So as soon as you see cues of a UTI, you should be getting a urinary tract, a urinary specimen. If you have signs of a pneumonia, you should be getting a sputum specimen. Signs of a bloodstream infection, you should be getting a bloodstream. You should be getting cultures of whatever you think is infected. If they don't know what's infected, they get cultures of everything because you need to identify the bacteria involved. But what they do is they will prescribe an antibiotic, the most common antibiotics for the most common bacteria that cause that problem.
Do you need an order to take culture?
That's a great question. You need an order to have the culture processed in lab.
So
You don't need a...
Just
If you don't need it, or the doc says, I don't need to culture it, then you throw it away. But go get them to pee in a cup anyway, just in case. Yes?
So this happened to me in simulation. I realized that I had to do a straight cap because my patient had urinary retention, and we knew that, but I didn't have an order for a specimen, and I realized as soon as I did it, I should have kept it.
Yeah.
Because what's the worst thing that happens?
Right, you throw it away. Exactly. And so if your patient comes in with a fever and they've got like sputum, just take the sputum. Just keep it in a cup somewhere. And then when you get the order for that, you know you've gotten a specimen before you gave antibiotics. The important part is to get the specimen before you give an antibiotic. Because once you give an antibiotic, the chances of it growing out the bacteria in charge, responsible are lower. You start affecting your culture results if they've already had antibiotics. So
They just need the date and time from when that
Yeah.
culture was collected.
Yeah, you just put it aside. So if they are coughing, grab a sputum culture. If they are having any signs of a UTI and they're going to go to the bathroom, you'd be like, here, take this with you. And basically that's what they're going to do when you come in because they know you got to get that specimen before you give the antibiotics. So, but then you're going to get an antibiotic that's most common. And then if your culture grows out something different, then they change the antibiotics. But the chances of it growing out something different are very small, unless you have something weird going on with your body. They know the most common the most common bacteria in certain things. There's different antibiotics or different bacteria in your lungs than are in your genital area. There's different bacteria on your skin than are in your lungs or in your genital area. So they will treat you with the proper antibiotics. There is one urinary analgesic. It's called Pyridium, or I can't say that other one, phenoxypyridine. All you need to know about it is that it does not take care of the infection. So if you are teaching anyone about their UTI, and they're like, oh yeah, there's this great med that takes away all the pain. Well, that's taking away the pain, but it's not treating the infection. And so now this is over the counter. It's called like Azo, or I forget all the other things it's called. But if you take this without the antibiotics, what's going to happen underneath the surface? Antibiotics are climbing up, and you're going to get a much worse UTI because you masked the pain, which is great, but you need to do it in conjunction with the antibiotics. So that's why they used to tell people before you go in to the urgent care for a UTI, don't take this prior to, because it would mess up the urinary tract. But now they're like, no, it's fine, just take it. But it does stain your urine reddish orange, so your urine will look more amber even if it's clear. It does stain things, but the big thing is that tell people that's not fixing anything. Even though it took away the pain from the UTI, you still got the bacteria. So don't take that without an antibiotic as well. So I think that's it. There's a couple more things that we do talk about frequently with urinary. There are alpha blockers and anti-spasmodics. Get to know them because we will use them whenever we need to relax the bladder, or if we need to allow for better flow from the bladder. Alpha blockers will relax the smooth muscle of the bladder. It will prevent spasm of the bladder. And if you have bacteria in your bladder, they will spasm. They'll react to that bacteria. You will also see them be used when we talk about prostate problems that are swelling up and constricting your urethra. These just relax everything and allow flow to be better. You usually see these alpha blockers. If you've been in Mars, you'll probably have seen those before. They are the most common relaxation for the bladder muscles and the bladder tract. You can have anti-spasmodics as well, but these are not as common as the alpha blockers. So those are what we can do. If the pain medicines aren't working and you're having a lot of urinary spasms, they may put you on an alpha blocker. Let's see, what else do we got? And this is education. So you guys probably can read through the education on the patient, but we do the teaching and communicating once we've kind of gotten the interventions in. Then we can teach our patient more towards discharge and stuff like that, how not to come back with the problem, the causes of the problem, and the education to prevent the problem from coming back. All right, and there's your remit guide. I kind of put everything together. You can see all I'm doing basically is just taking everything from those slides and dumping it into the column. What I would recommend if you're putting these together, so after the first lecture, when I don't make the slides for you anymore, you can see all I did was lift out existing cues and dump them in there, lift out and dump them in there. What I would suggest to you is retyping them or rewriting them, because that's part of a good study. If you're just going to copy paste, you didn't learn anything. Copy paste doesn't learn anything. But if you do rewrite your slides onto the remit guides, that's one time you heard it. You heard it one time in class. You maybe hear it one time if you re-listen to it. You hear it another time when you rewrite your notes. The more you rewrite your notes, the more times you hear it in your head. Because as you write, you talk it to yourself or you say it to yourself. So you need to hear things 7 times before it sticks in your brain. So just coming to class and looking over your notes, that's 2 times. Just coming to class, re-listening class, that's 2 times. And then rewriting your notes, that's 3 times. Do more. Physically put your hands in. So copy-paste does not count as a time. That's just a fine motor skill. It's not learning. So I would physically either retype or rewrite your notes multiple times if you learn that way. That's very helpful. But you can see these guides are very easy. I put them in the right format for you so that you can put them together, and then hopefully you learn them as you go through them. So that's the remit guide for that. So all UTIs are just an infection from some kind of bacteria. We know the treatments, we know the education for it. Glomerulonephritis is an infection, but it's not from the urinary tract. It is a post-viral infection. Glomerulonephritis comes as a post-viral infection like strep. Strep is the most common reason you get glomerulonephritis. So what this does is it doesn't work up your urinary tract to pyelonephritis like the bacterial UTIs do. This comes from a virus that's circulating around in your body. This attacks the glomerulus, which is the beginning of the kidney. So it doesn't usually have the same signs and symptoms as UTI because it's not coming up from the bottom. It's just something that's in your system. So what it's going to do is it's going to infect your glomerulus, which we do. I give you the full anatomy of the kidney in the next lecture. But the glomerulus is where everything from the blood gets into the waste, and then there's a reabsorption area there. It's basically a big filter of your kidney. And so if the kidney is broken, the filtering area is broken, you end up leaking proteins that you shouldn't leak. So this is a different infection than a UTI. It's a post-viral. And because you're leaking protein into the urine, you're going to have different signs and symptoms. This is also not it's a secondary infection, so it doesn't have as high of a fever as a primary bacterial infection. Did they tell you bacterial infections are high fever, inflammation, and viral or low fever, right? High grade, low grade fevers. So when we see a low-grade fever, that's usually a sign of inflammation or something viral, and high-grade fevers are usually bacterial. So UTIs will probably have more of a high-grade fever if they get involved because they're bacteria. This one is a post or a secondary infection, so it's a low-grade fever. The bubbly or foamy-colored urine is due to the proteins in the urine. And the edema that comes around and the high blood pressure. This goes back to our fluid balance. So we waste proteins. Basically, we're not supposed to get rid of our proteins. Our proteins are our building blocks of life. The kidney's supposed to keep them. But now the kidney's been damaged, and so proteins are leaving in our urine. So what does that leave in our bloodstream? How does that change our bloodstream? How does that change our body to lose proteins?
Fluid leaves the bloodstream.
So fluid will leave the bloodstream because albumin's what's holding fluid in the bloodstream, right? Because albumin's that thick protein that hangs around and circulates around in our bloodstream. We have lost it now because it got peed out. It didn't get held onto, it gets peed out. So the urine becomes foamy and proteiny, and that's all great, but what's happening inside our body is we've lost the proteins that live in our bloodstream. And so now we don't have as many thick things in our bloodstream, so water now leaves our bloodstream and goes to that no man's land. The cells were hydrated, you weren't dehydrated. So the fluid leaves the bloodstream because it's attracted to the areas that have more molecules in them, like the cells in the interstitial area. So you end up with edema. So with glomerulonephritis, you end up with edema. With UTIs, you don't have edema. There's no loss of anything other than there's bacteria in the bloodstream. Here we're losing protein, which causes edema. High blood pressure. Why do we have high blood pressure? Well, we didn't go over the jobs of the kidney strong enough. We have high blood pressure because the glomerulus is in charge of our blood pressure management on our kidney side. So when we damage our glomerulus, it ends up sending out signals to increase your blood pressure. It doesn't think it has enough blood. It's damaged and it's secreting a hormone it shouldn't, and that ups our blood pressure.
Does it ever decrease your blood pressure or no?
So it would decrease your blood pressure if you were talking about losing fluid. You're losing the protein. You're not really losing the fluid. There's still fluid in your bloodstream, but now it's going out to the tissues. So you're like, wow, we should have a low blood pressure. But this renin causes an increase in blood pressure. And because the damaged kidney is secreting renin, it's going to up your blood pressure by causing vasoconstriction.
Does it always release renin when it's damaged?
It does.
Okay.
Yes, the glomerulus, when it is damaged, releases renin, which is when we talk about our renal failure, why renal failure patients all have hypertension. Because damaged kidneys secrete renin, renin causes vasoconstriction. So this is because we do have damage to one of the jobs of the kidney, and so the high blood pressure. It's not a fluid balance issue, it's a hormone releasing issue. Headache is from a high blood pressure, and when we look at the urinalysis, it looks like they have an infection, like a UTI, but it's not a UTI. It's a different viral source. They need a different antibiotic. The one thing that makes it different is the high protein count. Regular UTIs do not have a high protein count. Glomerulonephritis does. The assessment is the same. We're still doing the Geo Assessment, the same labs to watch for things. Again, the symptoms are the treatments are almost exactly the same. We do want a urine specimen to see if there's any other underlying UTI, but they probably have a history of some kind of underlying, some kind of viral infection or bacterial infection. This is a secondary infection. If you're dumping protein, they're going to be asking about your history and whether you've had any infections in the past. Yes?
Is that why you should get like strep throat treated if you think you've had strep throat?
Yes. There are numerous. Strep throat goes to numerous problems. You will find out that it causes heart valve issues in block 4, and it causes glomerulonephritis. So yes, strep, disseminated strep or strep in the body that is untreated does start causing secondary infections. So we will treat this one with a little bit of a different antibiotic because it's a different source. We will do blood pressure reduction and diuretics because of the edema and the renin problem. But still fluid intake to flush anything out except if they are in actual renal failure. Hopefully we're not to that point because, again, that is a worsening cue. If we we let this keep going, then the next size is renal failure and sepsis. So we don't want that to keep going. Those are our worsening cues. Yes?
So is there any order on the edema? Is that periorbital early, or is that after the lower extremities?
It's probably, I don't know, it would probably take about 24 hours or so for really the fluid to shift like that. But it would happen pretty quickly. Once you start losing your proteins are what holds fluid in your bloodstream. So once you start wasting your proteins, you start getting edema.
Okay.
But definitely the extent of the edema is how long it's been going on. So remember, UTIs don't come with edema, but glomerulonephritis does. So when your patient's coming in and they're having, UTI symptoms, you pretty much say, oh, it's UTI. We'll just probably get assessment, get antibiotics. If they're coming in with this bubbly, foamy urine and swelling, that's supposed to be cues to make you think glomerulonephritis. In glomerulonephritis, you want to make sure that you're still monitoring the same things as UTI, and it's almost the same treatment as a UTI, just different antibiotics.
Did it start at the same time, like the swelling your legs and the swelling your
Yes, it could be really anywhere.
Is there an order for? No. Okay.
No, and I mean, you could have just basically lower extremity edema and then periorbital edema. You could have periorbital edema first. It really just depends on your body. But the edema is what does come pretty quickly after you lose proteins. Yes?
Why do we give a urinalysis then if we know that it's stemming from the nephritis?
Just to make sure. Well, one, a urinalysis is going to verify your cues because they're going to verify, oh, yep, we're losing proteins. So a lot of our labs that we get verify our ideas, okay? So the patient comes in with the main cues. They've got swelling, they've got foamy colored urine, and you're like, that looks like they have a history of strep that maybe they just got antibiotics for and they didn't take them, or they didn't fill it, or they didn't take all of them, or they just got them late. But you're saying this looks like glomerulonephritis. This has all the cues of glomerulonephritis. This is a confirmation test. Or you get your urinary, you get a urinalysis for some reason, and you see a high protein count, and you're like, that's weird, we shouldn't be wasting protein. And then you go in and your patient's got all those other signs and symptoms, and you're like, duh, this looks like glomerulonephritis. So the reason we have these signs, symptoms, or cues is to really just verify what we're looking at there. And then we have to decide, is this glomerulonephritis just there, and we have to treat it? Or is it getting worse? Or is it getting better? You have to kind of gauge. We don't know where we're finding this patient. Yes?
So when do you find out the BUN and creatinine? Is that something that would happen right along with your analysis? They'd get a
Yeah, probably they would. Yeah, probably they would go ahead if they were ordering labs. If the patient came in with these cues, and you report these cues. So let's just say you're seeing this patient and they didn't have anything. Maybe you're treating them for something else, but then they started having this foamy colored urine and some edema, and you're like, you probably are going to call the doc and say, hey, can we get a urinalysis? Because it looks like they might have something problem with their kidney. Maybe they have a decreased urine output too. Who knows? I don't know where they are in the spectrum. Patient could be anywhere, which is why we need to do a lot of application with patients so you can see. But when you see the cues that make you think this is not right, then you order the labs that go with it that will confirm it. The UA will show increased protein. They will get a BUN and creatinine probably at the same time to help you evaluate whether you're in a worsening state or not.
Because I was wondering, because then, like, with the glomerulonephritis, they're supposed to be drinking lots of water, and you're like telling them, are you drinking? Can I fill your water pitcher? But then as soon as you get the BUN that's too high, you're supposed to say, no, let's hold back.
So then you also need to look at what were some of your other cues for renal infection, for kidney infection, for acute renal failure. You would also look at your decreased urine output. We're not just go to the BUN and creatinine and be like, oh my God, we got to do a fluid restriction. Because again, remember, we are helping gather information, right? So we have a patient that comes in with this mess, and they got a BUN and creatinine. Their BUN and creatinine are high, but their urine output's okay. That's different. Let's flush. Your urine output's still okay. We'll keep an eye on the BUN and creatinine and the urine output, because that's really going to tell us whether our kidneys are functioning or not. If the kidneys are still putting out urine, all right, you're in a stage. And so that's where we're doing the renal failure next, because we have certain stages of renal failure.
So that's
that
what
you
you're
can be in.
really going to watch then is the urine output, because the retention, the hypertension, they're the same.
Right.
And
These don't have anything to do with your kidney, basically. They're just things that are happening because your kidney's been damaged. So now you can't use your blood pressure as a determinant of your fluid status, because your blood pressure is all out of whack. You can't use your edema as a sign of fluid status, because that's out of whack. Your kidneys are broken. So now to assess your fluid status in your kidney, you're going to have to look at your urine output and your BUN and creatinine. Not one of them is going to tell you, oh, you're immediately in renal failure. You have to stop all fluids. We'll talk about that after lunch. So when we start saying all these things go to acute renal failure, we talk about acute renal failure after lunch. So you'll see those. But you will watch all those things because they all give you a picture. You can be in certain stages of acute kidney failure, but once your urine output starts dropping, that's basically your confirmation that your kidneys are no longer working. The BUN and creatinine are not a definite, like, oh my God, you're in renal failure, stop everything. It's your urine output that decides that for you. So when that urine output starts dropping, then we've got issues. And the fluid retention, you're like, oh my God, it's both of them. Yeah, we don't know if the fluid retention is due to the fact that they've advanced into renal failure or if they just have glomerulonephritis. But you can imagine that if they do end up in a renal failure from glomerulonephritis, the fluid retention is going to be pretty good. It's going to be pretty extensive fluid retention because now we have two problems causing fluid retention. We've got the kidney can't get rid of fluid, and we're losing proteins. So whatever urine you are putting out has tons of proteins in it because we're wasting them. So it does get to be a pretty big... So yeah, you do have to monitor these patients because we don't know how to evaluate until we have more data. We can't put you in a category of you just have it or you're worsening until we get all this data. So you're right, you cannot tell just from here whether you have a worsening condition or not. You do have to start looking at all the other things too. Which is why I say as nurses, we always are looking, if you're already a mom, you're probably already there, or dad, you already know the worst case scenario, like your kid's going to try and kill themselves. They're just going to do it, and you're trying to prevent them from killing themselves. And patients is along the same way. We just don't want these things to advance, or if they are advanced, we want to know so that we can call out what we need. And if you're not sure, they have all this, but I don't know if they have kidney failure, well, what additional monitoring do you need to do? So this is what's going to make you a good nurse, is knowing what to look for. What's the worst thing that can happen, and what am I looking for to see if that worst thing is happening? And if the worst thing's not happening, then fine, we're just treating this, and then hopefully they're improving. But we're always on the lookout for the worst thing that's going to happen, or what's going to hurt our patient or make them worse. So we're always watching for that worsening condition and hoping it never happens. So that's why the Geo Assessment is so important, because it's all those things that we're going to be watching for. The Geo Assessment includes urine output. Just do that. Any kidney problems, check their urine output, because it's going to tell you whether you're worsening or not. If your urine output's not good, then you got a bigger problem. So yes, if your increased BU and creatinine and you're in acute renal failure and your urine output is dropping, then maybe we'll hold off on that intervention at that point.
And that's when you do a bladder scan and it would be empty.
Yeah, because your kidney not making anything. So they drop their urine output, you bladder scan them, their bladder's empty, you're like, uh-oh, we got something wrong. And then you would, if you don't have those labs to tell you, then you call the doc and say, you know what, patient has glomerulonephritis, they're not putting out any urine anymore, I think we need to do some more tests. And put it in their hands. But you've raised the flag. That's our job, is to raise flags when there's problems. The treatment for it is almost exactly the same. It's just a different kind of antibiotic. And we don't usually we don't need to worry about the peridium or the pain, because there's usually not as much pain with glomerulonephritis. We're just losing protein. But if they are swollen, that may seem counterintuitive to encourage fluid. But encouraging fluids does help flush. And so if they still have urine output, we aren't going to block off their fluid just because they're swollen. All right? Just because they're swollen, that's just a sign of glomerulonephritis. But if their urine output is adequate, they may have fluids. Now, if their urine output is not adequate and they are showing signs of renal failure, then that may be something that we need to, maybe not so much fluids. So that's a good thing to help glomerulonephritis, but we have to be careful with it if we've gone into a worsening condition. Does that make sense? Like, it's great for glomerulonephritis, but not great for renal failure. So if you're in a worsening condition, we may have to pull that intervention out of there. Does that make sense? And then the low sodium diet is different for glomerulonephritis versus UTI. We don't care in a UTI what your diet looks like, but because you've got swelling, we don't want to increase the amount of swelling in the body, and sodium increases fluid retention. So we don't want to increase our fluid retention at that point. We want to flush, but not increase retention of the fluid. We want it flushing and going out our working kidney until our kidney stops working. Hopefully it won't, because you found glomerulonephritis right away. You're giving them their antibiotics, and we're going to keep them out of renal failure. But if they came in renal failure, then we have to hold off on the fluids. The causes, like I said, these are secondary. This is usually secondary infections. So, we're almost ready for lunch, guys. Almost ready for lunch. Let's do all the obstructions. So, the infections were either just a straight UTI from the general area up, or you have glomerulonephritis with a secondary infection from a usually strep. Now we have obstructions, which could be stones, could be a giant prostate, Could be a giant prostate, could be a cancer in the bladder, anything like a tumor, anything that is causing you to avoid being able to pass urine out of your body. Urine that your kidney made but can't get out of the body. That's considered an obstruction. You're like, I know this. So urinary stones. I'm not going to spend the 7-minute video making you watch it in class because I know you can go home and click on this when you get home. Have your kids watch it. It's very interesting. It's 7 minutes and it basically shows you, except it uses the word stone former in a very judgmental way. Like, this person is a stone former. But it's very good about the different kinds of stones, how they form, where they form, and why they form. And I think it's a great video, so I'm going to let you watch that when you get home. What we are going to do is this patient's going to come in. I put pain as number 1 because that's what's going to bring them in. We were just talking about that on the break. Patients come in with pain. There is a stone stuck in your urinary tract. It hurts a lot, like a lot. Because basically this urinary tract is trying to squeeze the stone out. So there is spasm and extreme amounts of pain. It's colicky, it comes and goes, and it is basically all the patient is worried about is their pain. It hurts, yes.
Do you get pain when it's trying to pass, or do you have pain while it's in there?
So it depends on where it is. If it's in the kidney or in the bladder, it doesn't hurt.
So it's only when it's trying to pass.
When it's trying to come through one of those tracts. Now, kidney stones can be a little bit painful if they start blocking off and swelling the kidney, but usually they're only hurting when they get into the tracts and are trying to pass, because you can see the stone doesn't fit in there. In the bladder, they're just hanging out. They're just floating around, and unless they get stuck somewhere. So you can have a kidney stone that you've had for years that you didn't know about because it's just sitting in your bladder, being a stone. And, every now and then it kind of gets onto that sphincter and blocks something up, and you're like, and then it moves out of the way. So bladder stones don't hurt just having them. It hurts when they're trying to move through the urinary tract. So pain, pain, pain. That's usually what brings people in. So they can have kidney stones for years and not know about them, or renal stones or bladder stones for years. But it's when they try to pass that it hurts. Good question. So pain. Pink, red, or brown urine, because this stone, it's not a nice smooth river pebble. It's let's see if I can go back to the picture of it. Here. Let's see if we can, I don't know if I can blow this up. Let me see if I can blow this up so you can see it. It is actually like a little piece of volcanic rock. Let's see. It won't let me, the system I'm in. But if you go up there and if you look at a kidney stone or look at some pictures of kidney stones, they're jagged and they're rough. And so as they travel through the tract, they rip up the tract. They rip up the urinary tract. So not only does it hurt from the spasms, but it's actually it's like ripping as it comes down. It hurts. It hurts a lot. So they may actually be bleeding in the urinary tract, which means that what urine they do pass is pink or red or brown. They can have this urinary tract infection because, remember, we have a lot of bacteria just kind of living down there, and they're just looking for an opportunity in. And so a urethral stone that's down there close to the entrance that's ripping up things, that's an opening for a bacteria to just go in there and have lunch. So they are very highly prone to UTI because of the scraping up. And then when you look at your urinalysis on a patient with a stone, they have, of course, red blood cells, white blood cells. They've got, it's the same urinalysis as the UTI. But probably more red blood cells and probably more white blood cells because there's just much more. You've got a lot of openings in that urinary tract that's been scrapped up, and you have much higher risk of infection as well. If the stone gets stuck, that's where we see our worsening cues. So if this stone gets stuck somewhere and lodges, now no urine can get out. The kidney's still making it, but it can't get anywhere. And so when urine starts backing up into the kidney itself can only hold 5 to 7 milliliters of urine. The kidney is not meant to store urine. The kidney is meant to make it and pass it out. So if that, let's just say up in that cup, you got that urethral stone sitting right in there. That stone's blocking your ureter. Urine cannot get down to the bladder. Now, if you only have it in one, you're still making urine from your other kidney. So you may never see a decreased urine output. But what's happening is the one kidney that's getting blocked up, what's happening to it? It's making urine. It's making urine. It's trying to throw it out, but it's not going anywhere because there's a stuck in the path. So I wish I could draw. I want to draw on my picture. But that kidney starts to swell and swell and swell and swell. It's making urine, and the urine's not going anywhere, and that kidney is starting to swell. And a swelling kidney can become a damaged failure kidney. That kidney, it can cause renal failure to have a stuck stone. So it is important for us to go in there and avoid this hydronephosis, pyelonephritis, or kidney failure.
Is that reversible?
Yes, all kidney failure is, acute renal failure is reversible. So we'll talk about that after lunch when we do acute renal failure. What's that?
Once they remove the stone.
Once they remove the stone and you get the kidney decompressed, it will start reversing itself and healing itself. So again, the lab work, really we're going to be paying most attention to the urine output because that's going to be our cue as to you have kidney stones and pass it, or you have kidney stones causing a blockage. So we're always going to be looking at the urine output with a kidney stone and being worried about the urine output because that is our big cue. And there's some pictures of the stones. That's not going to feel good coming out a urinary tract. They are not smooth and easy to pass. They are jagged, they are rough, and they rip things up as they go down. So to take care of kidney stones, you have to decide where they are you have to evaluate where they are in this spectrum. Do they have urine output or do they not have urine output? Because that's going to change your interventions. If they have urine output, then just hose them full of fluid and pass that stone. Which the patient doesn't want to hear because they don't want to pass the stone. It hurts. But what we're going to do is we are going to pump them through a fluid. They don't have renal failure. They have good urine output. Let's just hose them full of fluid and dilute that urine and pass the stone out. Also, diluting the urine keeps new stones from forming or keeping those stones from getting bigger in the kidney. So fluid, fluid, fluid. Pain control, I put it number 2. The patient wants it number 1. So you can move pain to number 1 if you want to take care of your patient's pain and then fluids, but it's pain management and fluid. Get those kidneys passed. They probably will do a CT scan or an ultrasound just to be sure of where the stones are to see if there's any damage to that we didn't miss anything about the kidney infection. But strain all the stones. So you may think that's common sense if you're putting out a stone, but we do want to send any stones to the lab to figure out their makeup because that's going to help us do teaching about what caused it and how to prevent it in the future. So basically, fluid and pain control, fluid and pain control. This is where you might use those alpha blockers, those anti-spasmodics again, to help relax that urinary tract and let that stone drop. Because the more tense we are and the more pain and the more we hold on, if we're tightening things up, we're also keeping our smooth muscle from relaxing. So a lot of those alpha blockers, the tamsulosin, the Flomax, those are good for urine stones too because they relax your urinary tract, let that stone drop into the bladder or so. If they are not peeing, they have an obstruction. So you're going to, you could have a full bladder. If you're not peeing and you have a full bladder, where's your obstruction? In your urethra. That's where the stone's stuck. If you have no urine output, stones, and an empty bladder, then that stone could be anywhere from the kidney down to the bladder because none of the fluid's getting down to the bladder. So you're going to do all the stone interventions, plus we are going to bypass the obstruction. We have to bypass the obstruction to keep them out of renal failure. Because if that obstruction stays stuck, then we'll have to, that kidney could be damaged for good. So they'll put in a Foley. They can go to OR and do a nephrostomy tube. So I do have a thing later on where we do talk about all the different tubes. Antibiotics, because they have a high risk of infection. And this is where if the stone is lodged, they will do a couple of different procedures to help unlodge that stone. They have shockwave lithotripsy, where they just basically vibrate you until the stone breaks up. They have a Euroscope stent, so I do have pictures, I think, of all the different ones. This is where the shock waves are actually breaking up the kidney and stones into small ones that can pass. The The Euroscope Stents, this is a nephrolithotomy here, because they're actually physically going in and pulling the stone out of the kidney. And then they can also they can do a scope. They can put a scope up your urethra, through your bladder, up into the ureters, find it, and pull it out. So they can do scopes, they can do surgical intervention, they can do shockwave therapy for these. The thing that you're going to be giving them after you strain their stone or figure out what interventions they need and get those interventions done, you're going to teach the patient about their stones once they've been analyzed, okay? These are the 4 kinds of stones. Every single calcium oxalate uric acid, doesn't really what it's made out of. The more dehydrated you keep yourself, the easier it is to form stones. Crystals can't come together in a very dilute environment, but in a very concentrated environment full of junk and not a lot of water, those crystals just kind of magnet together and become stones. So the mainstay of treatment and maintaining yourself from getting stones is hydration. Limiting sodium and increasing citric acid. That citric acid keeps stones from coagulating together. Citric acid keeps those stones from forming. So these are the mainstays of treatment. We don't want, if they have special stones like uric acid, that's to avoid excess protein. If they have calcium-based stones, that's where they don't get to take too much extra calcium. We never tell a patient, don't eat protein, don't eat calcium. We're always telling them, when we tell them to limit, we mean just limit it down to the bare minimum that you need to survive, which is your USDA requirements. Okay? So that was something that got some people on a test, because they're like, oh, we're supposed to tell them not to eat protein. And I'm like, well, you got to have some protein to exist in life. They are not supposed to cut their protein completely out of their diet or cut calcium completely out of their diet. They're just supposed to keep it to a limited level. Okay? But every patient, no matter what kind of stone, dehydration, sodium, citric acid. My mom had a calcium stone. She's had stones numerous times, and she just doesn't go to the bathroom. She had knee replacement and got kidney stones after knee replacement because it hurt to get up and go to the bathroom. So she decided, because she's a genius, that, well, if I don't drink, I don't have to go to the bathroom, and it won't hurt my knee. So guess what? She's in the hospital with a kidney stone because she takes calcium, she takes all these extra supplements, and she didn't drink, and so she got these stones forming, and now she is a stone former. And so she went in. The first time they did a uroscope, pulled it out. The second time, she ended up getting septic because she didn't drink. She got a stone. This stone was higher up in her kidney. She went into renal failure, and she got sepsis. And I'm like, all you needed to do was drink some water, Mom. Now you're in the hospital with like a 1 month and home antibiotics and all this because she just didn't drink water. So what we need to do, and whether our patients listen to us or not, is not our control. We give them the information. What they do with it is up to them. On their second, third time in with the same problem, we could say, do you see a pattern now? Maybe try this now. So when we're doing this education, again, this education is not a priority in the immediate treatment of the problem, but it becomes a priority towards discharge and as they're improving. You don't have to worry about doing everything at once, but when your patient's improving, give them the education so they don't have the problem again.
So we need to memorize the sodium level to stay at, but not the protein and calcium level?
I would like you, because remember, I know you guys have limited brain space. It's fine. We are humans. These are the big treatment things. Okay. You can look this stuff up. If they have a uric acid stone, what I would like you to know, if they had a uric acid stone, well, uric acid is usually due to proteins and stuff like that. But if it's bolded, that's what I really want to point out to you. If I could point to things in a PowerPoint, that's how I point to things in a PowerPoint. Like, it's bolded. Remember it. Make a note of that. So if you're trying to save space on your notes, make sure the bolded stuff is included in there. And if things are bolded in your book, read it. Bolded is important. It's the way we point at you. So if they're bolded in there again, and so this one, it says prevent dehydration, limit sodium, increase citric acid. It's all there. I just basically copy paste, but I don't want you to copy paste. You're learning. Rewrite. That might be better for you. BPH is, again, just a obstruction. Cancers, tumors, they're just obstructions. So with urine stones, we wanted to catch the stones. We're not going to catch a stone here. This is an obstruction. This is an obstruction. The cues for it is that they have trouble peeing. Well, of course they have trouble peeing. Look at this thing. It's sitting right in front of the bladder. Women, we don't have to deal with this one. Hey, one thing we don't have to deal with. But for men, this is something, that as bladders, prostates enlarge as they age. It's just going to happen. It enlarges faster in some men than others, but this prostate enlargement causes a compression of the urethra. And so, of course, you're getting an obstruction. So what do you think you're going to see on a bladder scan? A full bladder. It can't get out. But you're going to have no urine output, but when you scan the bladder, you're like, aha, there's fluid in there, so we know our obstruction is in there. And on men, we're probably just going to assume it's a BPH, but how do you find out if it's a BPH? How do you find out if it's a big prostate? Boys? What's the test for it?
Bend over and outpatient.
Stick a finger up there, because this is your rectum right there, so they can see it pressing in on the rectum. They can feel it pressing in on the rectum. So that's every guy's fun time, is the prostate exam. But the prostate exam is there just to see, hey, you've got an obstruction. They probably aren't going to stick a finger up there. What are they? They're probably going to do an ultrasound. They're going to be nice to you guys. They don't stick things up there. Women, they get stuff stuck up there all the time. But basically, difficulty initiating stream, weak stream when it does initiate. You're peeing all the time, have frequency incontinence because this bladder is full and it's pressing down and there's obstruction. So they're constantly in the bathroom peeing. And when they do pee, it's weak and they don't empty their bladder all the way and they get UTIs. Usually when we go to get treatment, they probably do have some kind of obstruction, and this causes reflux and swelling of the kidney. And of course, you can see a pattern here. Every kidney problem, the worsening case is that you end up with acute renal failure. So we want to keep them out of acute renal failure. For BPH and prostate cancer, basically, they're going to do stuff to decrease the size of the prostate. So our treatment for kidney stones was let the stone pass, bypass it, the obstruction if we need to, but pass that stone, get the stone out. For prostate cancer, we don't just remove the prostate right away. They need the prostate. They're going to shrink the prostate, and they do that with testosterone blockers. Testosterone is what's causing this bladder to enlarge in the first place. So they will do testosterone blockers to reduce the size of it. They can also remove the testicles to reduce the testosterone level and shrink the prostate a little bit. But basically, we are just concerned with getting that prostate small enough to pass urine. They're not interested in removing all of it. They're just interested in shrinking it to the point that it can pass urine. Now, if it is cancerous, how do we know the difference between whether it's benign, which is what, if we go back and look at this, we have BPH, which is benign prostatic hypertrophy, and then we have cancer. Doesn't tell you, other than hematuria. They do a biopsy. So yeah, they will do. So there is a, did I have that in here? Did I skip PSA?
Yeah.
Okay. So the digital rectal exam is the fun one. That's the up the rectum just to see. They can kind of guesstimate if there are nodules on it or not nodules on it when they feel. They can kind of guesstimate based on that, but they're also going to do a prostate-specific antigen. It will not tell you cancer versus non-cancer. It just tells you, yep, the prostate's big. So that doesn't really tell you anything, and the biopsy is the best way to tell if you have the two. If it is prostate cancer, they can remove or radiate the prostate. But again, the goal of the treatment is reducing it and removing tumors. So what they will do a lot of times is radiation therapy, and they'll put like little pellets in the prostate and shrink the prostate that way. But whenever you have cancer, the treatment is to reduce or remove the tumor. So you don't have to, I don't think you have to study every single little piece of that, because In BPH, we just want to reduce it so that urine can flow. And in cancer, they will either reduce or remove the size of the prostate. But the prostate does have a function in the body. I'm trying to think what the prostate's function is. It doesn't make the semen. What does the prostate do? I don't remember. Sorry. This is not the man's and women's lecture, so I didn't look that up. But I will look that up for you. But anyway, they generally will only remove it if it is cancerous. Otherwise, we just are shrinking it. These, again, you can see they're coming up over and over again. You probably are going to see them on test questions or as part of your interventions, because when patients have trouble peeing, this does help them pee. So you can see, if you've taken care of patients with BPH, they've all got this on their MAR. Every patient with prostate issues has a alpha blocker on their MAR because it's going to help relax that urethra and pass it, but it's still not going to treat the actual prostate size. Yes?
It produces like a fluid that helps transport the sperm.
Like seminal fluid?
Yes.
Just chop it out, man.
Sperms is seminal fluid.
Sorry, guys, just remove it. I'm just like, just take it out. We take out whole organs all the time.
But I
Just
thought
take it out.
It causes all kinds of removing of it, like messes with the TERP. Like that's what we learned about the continuous bladder.
Oh, well, yeah, so when you are, I think I have all these treatments in the procedure section. So we do have all the procedures. So if I blow through them on the slide here, it's because they're coming up in the procedure
I just
section.
thought that removing it is a big deal because of the tissues they have to go through to get it.
And removing it does cause a lot of debris and a lot of
causes
mess.
other problems later on.
It's their testes too, or their.
Yeah, it's everything's down there. So basically, the takeaway is that they don't always remove all of it. Their goal is to shrink it enough to get urine output because they just know it's going to swell. So anyway, you can read the Teach and Communicate. I'm trying to get you through to lunch. So let's take a break because we went through the obstructions. We went through the infections, the obstructions. We have 2 genetic issues, and then we have some procedures to go through. So let's take a break for lunch. I'm going to pause this to do a few things wrong, but not everything. All right, so genetic problems. So we talked about infections, we talked about obstructions, and now we're talking about just, okay, sorry, you got a bad genetic draw. These are urinary problems that are not anybody's fault. There's no infection behind it. They are just bad genetic cards. So one of them is Nephrotic Syndrome. Nephrotic. So I think you may have noticed way back in the Glomerulonephritis, we had this word, and I did not highlight it, but let me just go back to glomerulonephritis real quick. We got to go back to the infection part. You notice how at the very top it says Nephrotic Syndrome? You may hear the word nephritic used around, especially by renal docs that like to impress and use big words. Nephritic syndrome means there's an infection. There's an I in the middle. Nephro means kidney, and itic means an infection. So nephritic syndrome is an infection. And so that's why I put it with glomerulonephritis, because nephritic syndrome just means there's an infection somewhere. And usually that means that the infection is due to something other than streptococcus. They'll call it nephritic syndrome if it's not due to streptococcus. But you may see that word nephritic, that meant infection. That's why I put the stars next to the I so that you could remember if you see the word nephritic, that is an infection. Nephrotic is a genetic problem, so different. They sound exactly the same. Their only difference is one letter, which is why there's a star next to those letters that differentiate them. So let me get back to them. So nephrotic syndrome has the star next to the O. And I like to think of that as an open glomerulus. Okay? Nephrotic syndrome. Genetically, this glomerulus loses protein. So it's very similar. The signs and symptoms and everything looks exactly the same as glomerulonephritis, except there's no fever. And this is just a bad genetic coding, and it usually happens mostly in kids. In fact, my son's best friend had nephrotic syndrome until he was 16 years old and would have relapses of nephrotic syndrome where he just basically, the glomerulus lost protein. So just like glomerulonephritis, the glomerulus is losing protein, but it's losing protein because it's infected and damaged. And that that causes you to lose protein and have swelling. Here you have kind of the same thing. There's no infection though. This is just genetic. There are high amounts of protein in the urine, meaning you're spilling protein into your urine, which means you do not have protein in your bloodstream. We read protein in the bloodstream by the lab albumin. Albumin is another name for protein. So albumin and protein are used interchangeably in our system. Albumin is the blood protein level. So if we are spilling protein, we lose albumin. Okay? So there will be high levels of protein in your urine specimen. And if you draw blood, there's going to be low levels of protein, right? Because it all got in the pee. So high amounts of the protein in the urine, low amounts of albumin, because albumin is a protein. So don't let that confuse you. Albumin and protein I'm using interchangeably here. But when we spill it all into the urine, it's not in the bloodstream, and so we have a low albumin level. That does lead to high blood pressure. This loss of albumin does cause, the damaged glomerulus. So basically, it's almost exactly the same, the glomerulus. So when we have the glomerulus is damaging things, protein is getting spilled, renin is being secreted, and renin causes high blood pressure. So we get high blood pressure, we get lack of protein, we get this high sodium, they get the same facial edema. They do have a couple of extra things that are going on because this is a long-term problem. This isn't just a one-time infection. This is something that is happening on and off throughout their childhood. So if this is, how do you tell the difference between glomerulonephritis and nephrotic syndrome?
No fever.
Well, no fever, no infection. Any other thoughts?
Their age and the patients.
Just there's no infection. And they're like, okay. They'll call it nephritic syndrome until they completely rule out infection, and then they're like, yep, you got nephrotic syndrome. So basically spilling in the protein, they're going to ask for a history. They're going to say, did you have any infections in the past? They're going to treat them for any other possible infections or viruses they might have. It's a diagnosis of a rule out, that basically this keeps happening and there's no infection. And so then they will call it nephrotic.
So what makes these patients seek help? Is it that they're swelling up?
They are swelling up, their blood pressure is high, they're probably going in for swelling. So my son's friend, he basically looked like a little Michelin boy. He looked like a fat, chubby little boy. And actually what takes him in is the fact that the swelling gets real bad, or their sodium level climbs like super high to their like super hypernatremic. So the blood pressure, sometimes we go in for a checkup, and a kid's blood pressure is like 160/90, and you're like, you're a kid. So the high blood pressure and the swelling are what usually bring people in. The protein in the urine is not it doesn't cause any pain. There's no pain, there's no other real symptoms. The swelling and the high blood pressure are what bring you in.
So it could be something they catch just because mom brings them in for regular checkups.
Yeah. So, this is something that, and then the high blood pressure and the high sodium are coming from the renin issue and the low serum proteins. They also might have some malnourishment as kids because they're losing proteins, and we use proteins to build muscles and build things and grow. But anyway, basically this is diagnosed usually in kids. Kids will grow out of nephrotic syndrome. They do have nephrotic syndrome in adults, but it's much rarer. So you'll probably hear about this more when you do pediatrics, but I did want to point out, just in case, it did show up on a couple of HESIs and a couple of NCLEX questions, this nephrotic syndrome. So I want you to correlate it to the same signs and symptoms as glomerulonephritis, but it is a longer term, it is a genetic problem. Some people are predisposed to it. And instead of having what we were talking, because there's no infection behind it, we're not worrying about a worsening infection. What we're worrying about is this fluid retention getting worse and worse to the point that it causes pulmonary edema. And so, of course, if they're coming in because they're pitting edema or having periorbital edema, we're hopefully going to catch it before it gets to the point where they have fluid overload in their lungs. We want to avoid that. And, of course, we want to avoid any acute kidney failure, which can happen from a kidney being damaged, even if it is genetically being damaged. But what we're going to do for it is exactly, so glomerulonephritis, what was the treatment for glomerulonephritis? Antibiotics. We can't do antibiotics for this one. This one, because it's a genetic problem, and what you will find out for most genetic or autoimmune problems, whenever something is autoimmune, which is what they think nephrotic syndrome is, a genetic predisposition to actually physically damaging your own glomerulus. So autoimmune diseases are when your body just gets bored and decides to attack something. Autoimmune diseases are actually on the rise, and we do think it's because we are we're too clean now. We're so clean that our immune system has nothing to do. If you think about how our immune systems evolved, our immune systems evolved to live in dirty, disgusting places with no no plumbing. There was no indoor plumbing. There was nothing. So our bodies actually evolved through hundreds and hundreds of years to be living in dirty places. And our immune system was in charge of keeping us from dying in these dirty, horrible places. Now we are super clean and highly sanitized, and our immune systems have nothing to do.
So you can take off these masks.
What's that? Yeah, let's get these masks off now. But actually, that could be something that we would see post-COVID, is that we have gotten so away from being sick that we may have a whole series of kids that come up with a bunch of autoimmune stuff and a bunch of people, because if you think about what our immune system does, it protects us from the world. But now we have everything that's protecting the world. We're keeping ourselves so isolated from the world that our immune system is bored. And when our immune system gets bored, it does stupid things like this. So it attacks your pancreas, it causes inflammatory conditions. But the long story short, and I get off my soapbox, step back. And I'm not saying go get dirty, but there isn't real harm in being dirty if you are a healthy human being. Like, that's what our immune system's for. It's when we have other health issues or our immune system isn't fully functional that, we should probably be nicer to it. But really, on normal, healthy kids, my kids were always eating dirt and stuff. They were out there eating dirt because I'm like, they need an immune system, so let's give it. But anyway, when something is autoimmune and we don't know why the immune system has turned on a certain organ, we just give it steroids, which we will find out is not the best solution. Steroids are great at suppressing our immune system, but they cause a lot of other side effects. But when we don't know what's going on, they will do steroids, non-steroidal anti-inflammatories. Basically, we're trying to remove the immune system from the situation. Nephrotic syndrome is an autoimmune genetic issue. And if the steroids or the non-steroidals don't hold it under control, this goes for almost any autoimmune disorder, then they ramp it up to either specific autoimmune things or actual anti-rejection drugs, which shut down your whole immune system big time. And that's what my son's best friend was on, tacrolimus, which is a chemotherapy drug. It's an anti-rejection drug. It's where they give organ transplants to keep you from rejecting an organ, but it shuts down his whole immune system. He was always sick because he didn't have an immune system. So the poor boy was Michelin man, swollen all the time. We went on a road trip, and he was on a low-sodium diet at 1,200 milligrams a day. There's no way. Can you imagine going on a road trip? We couldn't stop anywhere because one meal at a fast food restaurant is 1,200 milligrams of sodium. So I was like, it was like taking a little old man on a road trip. We can't stop at McDonald's. We can't stop at Chick-fil-A. We can't go to In-N-Out. Like, you can't have anything there. Okay. So we packed healthy snacks, and we were a healthy family for a little while. But basically, nephrotic syndrome, they are just trying to shut down the immune system. They don't know what's causing it. And most autoimmune systems, we're going to say, all right, it's steroids or an anti-inflammatory or an anti-rejection kind of drug. So I'm not going to make you memorize all of them. We'll be talking about them as we talk about autoimmune diseases, but that's how we're going to treat it. And we're going to do symptom controls, diuretics, low sodium diet to keep fluid from retaining, try to keep them from being as unswollen as possible. And because they are more prone to hyperlipidemia, they are more prone for clots and stuff, so they may have them on anticoagulants. I know my son's friend wasn't, but they may do that because of the increased risk of hyperlipidemia. So if someone comes to you and they have a history of of nephrotic syndrome, just know that's genetic autoimmune disease. And whenever I say something's genetic or autoimmune, you're just like, no, there's no real treatment for it. We just hope you grow out of it at some point. Some of these patients may end up to kidney transplant levels if they can't get it under control, because if the kidney is constantly wasting protein and you're malnourished and you're swollen all the time, if it does not heal on its own and it doesn't get better, then that may move to something where they have to remove that kidney or do something with it. The same way if you lose your pancreas, they give you insulin and they replace it and you're like, no, this is what it is. You don't have a pancreas anymore. We kind of do that with nephrotic syndrome. So just, teach your patient to avoid illnesses, stress. They will be on a low sodium diet. If they're on diuretics or blood pressure medication, they will need that to control their symptoms. Can't have a little kid wandering around with a blood pressure of 160 over 90 and being swollen all the time. So they're just going to manage symptoms until it either goes away or they're in kidney failure. And the same thing about polycystic kidney disease. This is another terrible genetic bad card. This is where the kidney just develops cyst. If you look, this is a normal-sized kidney, and this is a polycystic kidney. So when we talk about men's and women's, you might have women that have polycystic ovary. This is very similar to polycystic ovary and just this polycystic kidney, which means instead of being a functional kidney, it's full of junk. This is also a genetic, there's something programmed in your genes that sends your kidneys into making cysts instead of making actual urine and proper kidney tissue. This is something that happens slowly over time, usually is not detected at all until they have kidneys this size. And the main symptom, hypertension. And why do we have hypertension with kidney disorders? Renin, yay, blame the renin. Anytime the kidney muscle tissue gets damaged, it secretes renin, and you will see that in the renal failure slide. Renin sends off a renin-angiotensin-aldosterone system, and that increases your fluid retention and your blood pressure. It's supposed to be helpful, but damaged kidneys send off renin when they shouldn't. What would you do? What would your blood pressure medicine be for a patient that is having too much renin? An ARB or an ACE inhibitor. Those are what I consider the renal blood pressure medicines. So ARBs and ACE inhibitors work in that system. So this is the renin-angiotensin-aldosterone system. That's how it's causing fluid retention and vasoconstriction. So if you are on an ACE inhibitor or an ARB, it stops that cycle. So this kidney can throw renin out like nobody's business, but with ACE inhibitors and ARBs, you're stopping that cycle. ACE inhibitors are the angiotensin conversion enzyme. So we stop it there, so it never gets converted to angiotensin or aldosterone. It never becomes a vasoconstrictor or a fluid retention because those are the hormones that it turns into. So we stop the cycle there. And ARBs are angiotensin receptor blockers and keep you from responding. We let the whole system turn into whatever, but then the system doesn't respond to it. So basically, if you're on an ACE inhibitor or an ARB, you are no longer retaining fluid or sodium. That's what renin does. So it just basically shuts off that system. And so damaged kidneys release renin, so they put them on an ACE inhibitor or an ARB to control their blood pressure. Because the problem is renin, so we just stop the cycle. And ACE inhibitors and ARBs stop the cycle. So if you have a kidney failure patient and they have high blood pressure, I bet you $1 million that's how they choose those medications. Because we got a kidney problem that's causing your blood pressure. So we're going to fix the blood pressure with a kidney solution, which is an ACE inhibitor or ARB. So now you know, the more you know. But they have hypertension because of the renin. They have heaviness and in their back and sides. Well, you're carrying around, instead of little kidneys, you're carrying around huge kidneys. Of course it's going to, you're pregnant with kidneys. So yes, heaviness in the backside and abdomen, headaches because of high blood pressure, and if the cysts rupture, they may have blood in their urine. But it's really quiet. The problem is that it does actually, these organs do fail. And so it's basically 50-50 chance whether you're going to end up in kidney failure or not with polycystic kidneys. So whenever it's something genetic or autoimmune, you get to put on your sad face and say, oh, sorry, we don't really have anything for you. This is something where you're going to keep an eye out because basically they're going to go to chronic renal failure. And we're just keeping an eye on that. There isn't anything we can really do. There is no cure for it. It's symptomatic treatment only. And when something is a genetic disease, we ask the patients to get some genetic counseling because you're probably going to pass it on to your children. And you want your children to have these polycystic kidneys. So whenever something is a genetic function and they do find out about it, they probably, and unfortunately most people don't find out that they have polycystic kidneys until they're older and they probably already had kids. But genetic counseling to help any kids identify it, and maybe they'll do treatment for it, but right now there is no treatment for it, so it's symptom control, just like nephrotic syndrome is symptom control, so is polycystic kidney disease. Let's see, what else do we want to say? These are the procedures, and then I think we'll just play with some questions and see how you feel with some questions. But these are the procedures for any of the things, because I separate out procedures, because when we are learning about procedures, like you have that remit guide, we want to recognize it, we want to evaluate, is it stable, worsening, or improving? We know how to intervene, we know how to treat it. These are all interventions, but when you have a procedure, I like to know what do you expect after the procedure and what do you not expect after the procedure, because those are the key things why we're learning about these procedures. We don't perform them, we don't do them, but we watch the patients before and after them. So I put everything kind of in one so that you can just know a little bit about each procedure, recognize them, and then know how to take care of your patient after them. So this is a little bit more information about. These are the stone removal procedures that we talked about. We have the shockwave lithotripsy. We've got the Euroscope, which is going up through the urethra, and they can go in there and put in a stent. They can take out stones, and then we actually have where they go into the kidney to remove the stone. These are the prostate surgery procedures, and again, this just is more information. I don't test you on which procedure is which. Again, we're just going to find out what are we going to do after all these procedures. This is a bladder removal, a cystectomy. If your patient has a cystectomy on their chart, they've actually had their bladder removed. So a nephrectomy is where they remove the kidney. So nephro is kidney, cysto is bladder. So a nephrectomy is remove the kidney, a cystectomy is remove the bladder, and these are usually for tumors. A nephrectomy is kidney. You can have partial nephrectomies or full nephrectomies. It would depend. But again, we are still looking for all the same symptoms out of these procedures. And I guess you can guess what we're going to be expecting after these procedures. They're having a procedure in their kidney. I would expect pain. We expect pain after any procedure. It doesn't mean we don't treat it. It just means I'm not too worried about it. We expect pain. We expect a urinary drainage catheter. This is the one kind of exception to your rules. We need to closely monitor urine output. And if they've done a procedure in the urinary area, it acts as your drain, right? Your urinary output, this isn't just for your own convenience so they don't wet the bed. This is actually a drain from the procedure and a way to monitor your urine output for the procedure. So your urinary drainage catheter, they kind of, after any urinary procedure, you're going to have a catheter in. And you're allowed to have the catheter in because it's the drain. How else are we going to see? Where are the kidneys going to drain to? Where is your bladder going to drain to? Where is that stuff going to drain to? It's going to drain to the urinary tract. So urinary drainage catheters, and not when I talk about urinary drainage catheters, we're not only talking about Foley's. We're talking about any, a suprapubic, a nephrostomy tube, a urostomy tube, which I have those in later in the slide as well. So when I'm talking about a urinary drainage catheter, if you had a bladder removal, you might not have a Foley. You don't have a bladder anymore. They may put in a suprapubic catheter, which is a drainage catheter that comes straight out of the bladder area to drain. But remember, these are not only urine monitors, they're drains for the surgery procedure. So it's just like having a JP drain or a wound vac or anything. Your urinary drainage catheter is also where you're going to see the wound drainage coming from, because that's where you did your surgery. So we expect it to be pink or brown or clotty because we just did surgery in that area, right? We just removed either a stone or some tissue or some of the kidney or some of the bladder. So of course any blood or any drainage from that or any tissue is going to pass out in your urinary drainage system, whatever it is. So that's not only for measuring urine output, it's also your drain. We would expect, or I would not be surprised to see continuous bladder irrigation on any patient with these procedures, because any patient that is going to have a high amount of drainage out of their wound will probably occlude that catheter, because if you have a lot of tissue or a lot of blood or clots, that could occlude your catheter, and that's your wound drain. So if your wound drain gets occluded, then it can't drain anymore. So CBI is just there to keep your catheter open, whatever the catheter is. Always oral hydration unless your kidney is damaged to the point of no urine output. But if you have urine output, they're going to be putting fluid in there because we want to flush that stuff out and create dilute urine so that drainage can stay open, right? You might also have surgical drains, but the main surgical drain is urinary drainage catheter. Anytime we go into any abdominal surgery or any abdominal procedure where they physically go in and move bowel around, so if you have to move bowel to get to the organ, you're going to have decreased bowel sounds. So if you have to get to the kidney, they will go in on the backside and try not to move your bowels around. But if you're going in to get bladder surgery, they're going to pick up the bowels and move it out of the way of the bladder. And whenever you pick up and move bowels around, you're going to have decreased bowel sounds after surgery. Also, anesthesia decreases your bowel sounds. So it depends on the procedure, but that is down there at the bottom because that could be a possibility of what we expect. What we do not expect are complications of the procedure, are frank, bright red blood. Now, pink or brown, so this is a little picture of the difference. This would be okay, not okay. Okay, not okay. So frank red blood, and I'm not talking about this. I'm talking about like it looks like blood is coming out, like that looks like an artery. That's frank red blood, and frank red blood means there is some kind of new bleeding going on. And remember, because your urine catheter is your wound drainage, that's your wound bleeding, and we would need to let somebody know about that. Turner-Cullen sign, did you learn about those? Turner sign, I think I have it somewhere, but Turner sign is bruising on your flank. So if you're bruising back in here, that's your kidney bruising. That could be a sign of bleeding on top of your kidney. So frank bleeding or bruising here is Turner sign, and Cullen sign is around the umbilicus. So I like to think of Turner as a T on your side, and Cullen's as a C around your umbilicus. Those are both signs of abdominal bleeding. So we will use Turner and Cullen sign for any time you could have abdominal bleeding. But if you went in and did a nephrectomy and it was bleeding and you weren't seeing the bleeding coming out in the drain, it could be bleeding into your tissues, and that would leave you with a bruise. And the bruises are, if it's flank bruising or abdominal bruising, that's a sign of internal bleeding. It's a pretty late sign, because by the time you see a bruise on the skin, you've bled quite a bit. So decreased blood pressure, increased heart rate. But basically, hopefully, we will see it come out in the urine drainage catheter, because that's our drain. Of course, acute renal failure is a risk anytime you go in and do anything goofing around in the urinary tract. Infection, and we don't expect no bowel sounds, which is paralytic ileus. I'll talk more about that in GI. But there's a big difference between no bowel sounds and hypoactive bowel sounds. But I'll save that for GI. So, of course, we're going to monitor. Oh, here's the picture of Turner and Cullen signs. This is Turner, the T on the flank, and this is Cullen's right around the umbilical cord. So we'll use that again in trauma or any kind of abdominal surgery. That is your sign of bleeding if you see it. So we'll make sure we give them pain medicine, keep those urinary drainage catheters, the surgical drains open, irrigated, draining. This is kind of, common sense, right? Use your common sense. I believe in it. Let's bring it back. Yes?
Where do these patients go after surgery?
They will go just to a regular floor. Regular floor. Most regular medical surgical floors If you have no comorbidities, you're going to a medical surgical floor because you don't need to be monitored. Now, if you have a urinary procedure and also heart failure, then you're going to a telemetry floor because you've got other comorbidities involved. If it's just a straight urinary procedure and you do have a urinary catheter, they usually do like to monitor you overnight just to make sure that there's no kidney failure or anything damaging going on or no bleeding. Some patients go home with their urinary drainage catheters. So it would depend, but if they are going somewhere, it's not a real high acuity floor. Even the CBI is just rinsing the bladder. It's not a high risk procedure.
It just keeps you busy having to change it.
What's that?
It just keeps you busy having to change it.
Yes, it's busy, but it's not like really going to change your electrolytes or do anything big. So they're regular on a med-surg floor, usually post-surgical med-surg floor. But if they have other things going on, they might be risked up. But basically, there really isn't a lot to urinary procedures. We just want to tell the patient, because a lot of them will freak out. They're like, there's blood in my urine. Well, of course there's blood in your urine. You just had a urinary procedure. Yeah, we expect a little bit of blood, but not a lot. We expect a little bit of oozing and bleeding and clot and sediment, but we don't expect your drainage catheter to become occluded. So just be an eye out for those complications. They're mostly common sense, but I do want to make sure that bleeding, renal failure, paralytic ileocecal infection are your big things we don't expect after a urinary procedure. And then this is just a little bit more about the CBI. You know, you learned it in lab. This is your second time hearing about it. I will bring it to class next week so you can play with it. But again, this is just a flush of your bladder. This is not supposed to be a highly intense procedure that you have to be skilled checked off on. But it does require a 3-way catheter. One of them is, the middle one is for your urine output, just like a regular Foley. The one on the side is where you place the sterile irrigant bag. And basically you're just bathing the bladder with irrigant, and it's going to come out the drainage side. So you're putting it into the bladder, it rotates around your bladder and drains out with the rest of your urine. So that it needs a 3-way catheter, and it needs sterile irrigant, and I will bring that to class next week so you can play with it. And I have a little bottle bladder. Does she play with the bottle and show you the red bottle and how it fluctuates through? So CBI is really just there to keep any clots, debris, tissue from blocking up your drainage catheter. And if you do have CBI, we do expect that in your urine drainage bag, you should have more than what you put into the bladder, right? If we irrigate that bladder with a liter of saline, we expect that liter of saline to be back in the urine bag, plus some, because that's your actual urine output. So that's all that is we expect the urine drainage bag to have the irrigation fluid plus your urine output. That irrigation fluid, if it's not coming out, there's something wrong. So we expect clots and sediment in the drainage bag. That's the whole reason you have CBI, is to get that stuff out. We expect it to be pink or reddish urine. We just don't expect it to be frank. We want to make sure that all the time, if you are infusing fluid into the bladder to circulate around and pee out, you've got to make sure it's coming out. You can't be putting fluid into your bladder and then nothing coming out, because that means that we're just infusing and it's expanding, and we've got a problem. So it should always be draining continuously. The patient may feel like they're full because we're keeping that bladder full with irrigant. And so, yes, tell them that's normal. They might have bladder spasms because this is room temperature. It's 70 degrees, the fluid that we're putting in their bladder. You're 98 degrees, so that's a 20-degree difference. That might cause the bladder to spasm a little bit. So just, if you know why, you can tell the patient why, because if they're complaining, I got to pee and it's spasming and it hurts, if you tell them why, they will accept, that you'll understand that a little better. You don't think there's anything wrong. Patients are always hypervigilant for something going wrong. And so if you explain to them why they're having what they're having, they don't get as anxious about something going wrong. Oh yeah, well, we're putting fluid in your bladder, but it's draining right out again. But the coldness, and so sometimes we try to warm that fluid a little bit to help.
She had said to get warm blankets.
Yes, so that's where it should be room temperature or warmer. The warmer it is, the less chance of bladder spasms you have. So if you can warm the fluid, or if you could put blankets on them to kind of help them warm up that fluid that's going in. But that happens with IV fluids too. If we give them high amounts of IV fluids, remember, IV fluid is room temperature. It's 70-some degrees. and you're putting it in a 98-degree person, if you put enough fluid in, they're going to get hypothermic. That's something that we don't have to worry about till you go into ED, but when the ED is giving 2, 3, 4, 5 bags of fluid to a patient to replace fluid volume, they can become hypothermic very easily because you're giving them 70-degree fluid, and that drops your body temperature. So just kind of be aware of that, and sometimes the more you know, the more you can help your patients. So, what we don't expect when you're having CBI is, again, that the drainage doesn't come out, because where did it go? We don't expect bleeding, because that's a sign of a new problem. And uncomfortableness and need to void is different than physical pain. Okay, like, oh, that's hurting me. That's not okay. Something's going on. Probably that bladder is distending to the point of causing pain. Like, uncomfort and need to void is different than actual pain. If it's causing pain, there's something wrong in the system. So that would be something that I would want to report. Like, if you're complaining of pain, well, what kind of pain? Is it just fullness pain, or is it like actually like 9 out of 10 pain? Because 9 out of 10 pain, we don't expect that. I would expect discomfort, 1, 2 maybe, feels full, but not actual pain. So I'll bring that to class next week, and we'll play with the CBI so that you understand that a little bit more. And then here are all the different kinds of things that we can put in to drain a patient. So we'll just start with the suprapubic. Has anybody seen a suprapubic? Sometimes patients do have suprapubics. This is directly into the bladder, mostly because either the urethra is damaged, blocked, removed, or that they just want to have a direct output from the bladder, usually because there's something wrong with the urethra. There is high risk of infections as having a regular catheter up there, but usually if you have a stone, an obstruction, something that does not allow you to pass the Foley the usual way, but you still need a drainage system from the bladder, then the suprapubic is what they're going to use. It is temporary. It should not be in there for long because it is high risk of infection. It's also high risk of poor drainage.
Is this on the CAUTI list as well?
Oh, yeah.
So this is all fully, all...
It's a catheter-associated urinary tract infection.
So any kind of catheter.
It's a catheter, yeah. I mean, that is just as easily infected, and it's going into the urinary tract, so it would be counted as a CAUTI if they got an infection from this. But this, you can tell, if you're laying on your back, how's that urine going to get out of there? It's not until the bladder is completely full and then pushing up and out. Patients laying on their back with a suprapubic do not drain.
Do you know what's interesting about that? The
What's
one
that?
that I saw was actually paraplegic.
So paraplegics, they used to get them. They are not recommending them anymore because of the high risk of infection. They're probably not going to pull it out of someone that already has it. But they might also have scar tissue because if you've been self-catheterizing for so long or have so many infections that you've scarred your urethra, then that's the only way to get fluid out. So that's probably where paraplegics have either had so many infections or scarred their urethra that they can't use a regular self-catheterization. But suprapubic, you can see they're high risk of infections because it's going directly into the bladder, and they don't drain. So one of the big things with the suprapubic is definitely keep your patient on their side to promote drainage on there. So if you're taking care of that patient, that's not the best position for them because they won't drain. So side to side to promote drainage, and all of these catheters we can irrigate if we need to, because getting drainage out is the most important. We don't, because if drainage doesn't come out, it's going to back up to the kidney and cause kidney damage. So if they're not draining for some other reason, then we can irrigate them and clear them out. But all irrigation to any urinary catheter should be sterile irrigation. Let's see what else we got. We got the nephrostomy tube. This is a tube that it's in the nephro, it's in the kidney. This is an actual kidney that is a tube that is punctured into the kidney. They'll do it surgically or in interventional radiology. Why do you think we would put a tube directly into the kidney? Ureter's blocked. You can't get, because we would rather fluid drain out of the kidney down the ureter into the bladder. That's the best path for it. It's got to get away from the kidney. But if your ureter is blocked for something, then they will put in this nephrostomy tube, which is a little tube, pigtail, poked right through there, and sits in the renal pelvis. That's the little tiny collection area at the bottom of your kidney. The renal pelvis is what can only hold 3 to 5 milliliters of urine. That's not a lot. You make that in like 10 minutes. I mean, if you're making 30 to 50 an hour, you're making that in 10 minutes. So that can easily start causing swelling if it gets occluded. The only reason they would put those in is because you can't use any other pathway to get urine out. They are very high risk of infection. You've got it directly going into the kidney. If they stop draining for any reason, that kidney is going to swell because it's continually producing urine, but it can't get out, it's going to swell. Also very high risk of infection. This is a majorly vascular organ, and we're just got a catheter going directly into it. Also, it could also have a risk of bleeding. You just punctured a vascular organ and put something in there, so you want to keep an eye out on bleeding. But you would want to make sure that it is continuously draining, which means not checking on them every 4 hours. When I say with the CBI and the suprapubic and all these things that they should be continuously draining, whenever you have a urine catheter, you should be putting your eyes on it every few hours to make sure that it is draining. Because you don't want to wait 4 to 8 hours to realize your urine catheter never drained. You've got damage going on if they never drained. So when I'm saying check on them, these don't have fluid running into them. The CBI, you should be checking those every hour or half hour for drainage. You don't need to do an invasive assessment, just walking in and making sure it's draining out, because you're putting fluid in that should be constantly having fluid out. These might not be constantly having fluid out, but they should be having fluid out like every half hour or so. So go in there and check them every now and then. Make sure that there is fluid in the bag, because the longer you wait to check on them, if there's something wrong, that's gone bad pretty quick. So this one, if this one stops draining, that kidney's going to be damaged within an hour or two. Suprapubic catheter, it's going to take a couple hours before that no drainage catches up to the kidney. But with this one's pretty risky. So make sure that it is continuously drainage. And if you do need to irrigate it, don't put more than 5 milliliters in there, because you're just going to blow up the kidney. So with a regular catheter, you can irrigate it with a lot more fluid because you're putting it into a bladder. But in a kidney, it can't handle that fluid, and it's already in there because you have a blocked ureter. So don't go shoving 30 milliliters of irrigant into it, because all you're going to do is blow up the kidney. So just be careful when you see those, and that's what you're doing, is you're just watching the drainage bag. And then let's see, what else do we got? We got the diversions. So let's say you had a tumor. They had to remove your bladder. Well, you don't have a bladder anymore. So you can't have a Foley, you can't have a suprapubic, because your bladder's gone. So if your bladder's gone, we have to have a way for urine to get out of the body. So they will do an ostomy. Ostomy is a way for fluid to get out. I mean, an ostomy from your colon is going to put out poop. An ostomy from your ureters is going to put out pee. So ostomies are going to be permanent because you've lost a piece of your urinary tract. There are 2 different kinds of ostomies. One is incontinent and one is continent. Do we know what that word means, continent and incontinent? Control. Continent means control. So with an incontinent ostomy, you have no control over the urine output. It just dribbles out as it's being made. It's going to dribble out into a bag. It doesn't mean your patient's wetting the bed. It means that they are just dribbling out constantly. That's what incontinent means. That's normal for this. It's incontinent. You can't control it. It's just as kidneys make it, it's going to pee out into a bag. This one is continent, meaning it's got some control, because they make a false bladder. Yay! Why wouldn't we want one of those? So the reason the doctor and the patient pick whether it's a continent or incontinent diversion. This is a long-term issue. You've either lost your ureter, you lost your urethra, you lost your bladder. They have to do a permanent change. So if they do, you get to choose, or a patient usually gets to choose, whether it's going to be continent or incontinent. Continent means they make a false bladder, and the patient needs to self-catheterize that bladder to empty, because this false bladder is made out of intestine. It's not a real bladder. It's made out of a piece of colon. So that piece of colon can distend. It's a piece of tissue. It's vascularized, it can distend, but it has no sensation. It's not a real bladder. It has no sensation, it has no nerves, it has no detrusor muscle to push urine out. So the only way for urine to get out of this thing is to self-catheterize it. So if your patient is a completely competent patient that wants control over their life, this is a great choice because they can just go to the bathroom, put in a urinary catheter, drain it into the toilet, pull out the urinary catheter, clean it off, and then go on about their day. They do have to physically drain it, though, probably even more than every 4 to 6 hours, but we want to intermittently drain it because when that bladder gets full, how will they know their bladder's full? They don't have a sensation anymore. How will they know that this gets full? It's going to leak. It's going to leak. So they're going to drain it on a regular schedule to avoid leaks. Okay? But this one, they have to drain with a catheter. And they need to be an eye out. They're going to be cleaning. And, we have to do sterile for catheters because we are involved with multiple patients. And we can transfer diseases between patients. These patients are just taking care of themselves. And the only person that's going to touch that is them. They can do catheterization with clean aseptic equipment. Aseptic means as clean as possible. It does not have to be sterile. They can keep these catheters, they can wash them off with soap and water and put them in a Ziploc baggie and keep them in their purse or their bags. And then they can catheterize themselves, and they just have to wash their hands prior to, use their soapy clean thing and go in and do their drainage. In a hospital environment, you are sterile because you've touched multiple patients and we don't want to cross-contaminate patients. The patients at home, a catheter insertion can be done cleanly. It doesn't have to be 100% sterile. The reason we do it sterilely in hospital environments is because we see multiple patients and we don't want to cross-contaminate. So we are very careful with not cross-contaminating. The patients are doing this cleanly. They are trained to do it. If you have a patient that's maybe 80 years old and bedridden, this probably is not the best choice for them. Or maybe patients just don't want to deal with self-catheterizing themselves. They can choose to have the bag, and that is incontinent, and that's where it's just going to dribble out. So patients get the choice, or sometimes the docs and the families make the choice for the patient on whether their diversion is going to be incontinent or continent. But this one's going to have a stoma and a bag. The continent one looks a little bit more like just an open belly button because it's got reflux valves in there to prevent leakage unless it gets overfull, and then it will leak. So, a little bit about that. There is possibly a question, and most people are like, I didn't know the difference. And I'm like, it was in your slides. But, so I'm pointing it out to you. And then I put neurogenic bladder in here just because it is a bladder thing, and we've talked about it. I don't know if you've talked about it during multiple different things, but neurogenic bladder just means that the bladder sensation is missing or wrong. So a neurogenic bladder could be from any disease that damages the nerves or the brain. So you can get a neurogenic bladder after a spinal cord injury. You can get a neurogenic bladder after a stroke or Parkinson, any of these, anything that damages nerves. A neurogenic bladder can be overactive or it can be completely underactive. So a neurogenic bladder does not mean a paralyzed bladder. It depends. A neurogenic bladder just means something's wrong with the nerve innervation, which could make it overactive or paralyzed, and they have some different treatments. If you have an overactive bladder, they're going to try and get you to do something and try to, not void every time you need to go because your bladder is just obviously sending off crazy, stupid signals. They have figured out that there's no UTI. You don't get just a neurogenic bladder diagnosis. You'll have to be ruled out, and they have to do a bunch of tests to get a neurogenic bladder diagnosis. But if you have an overactive bladder from no other cause other than nerve dysfunction, then they will train you to ignore those dysfunctional nerve signals. You don't really need to go all the time, and so you time your voiding schedule. If you have a paralyzed bladder, then you might need to do those intermittent catheterizations like a patient with a spinal cord injury. But if they're doing it every 3 to 4 hours and they get multiple infections, they can scar their urethra and their bladder and end up with a suprapubic. But they also have bladder pacemakers. So some patients with neurogenic bladders may have a bladder pacemaker. which I put a little picture of it up there because I thought that was interesting. It's a little pacemaker that basically sends a signal to the bladder to empty every 3 to 4 hours, sends a signal to empty. It basically stimulates that detrusor muscle if it wasn't stimulated on its own by its own nerves. And they have a little remote control where they can say, I want to pee. And then there's an urge to pee. So they do have bladder pacemakers as well. So I just wanted to kind of point that out there as just some fun, interesting information. And urethral catheters, you know about them, but I just have a video there that does go through the irrigation repositioning, and I think it goes through CBI as well. So some more. The more you hear this stuff, the better you feel about it. Here's a little bit on CAUTI. We've talked a lot about that. But if you are at the hospital, insert with sterile technique because that minimizes cross-contamination. At home, patients at home and caregivers at home, they're going to reuse their supplies. They're going to clean them with soap and water, and they're going to do it as clean as possible. Keep their things clean to reduce the amount of infection in there. And I think that's all I have. These are just steps, and again, this is just more for your knowledge for clinical rather than testing. But I will come and I'll demo that next week if you want to play with those. That's it. So, I've talked to you enough.